So good morning. I'm privileged to have the opportunity to present. I'm from Windsor, Ontario. So for those of you who were at the river, if you looked across the river, that's Canada, and that's Windsor. So welcome. And I'll just continue. Is other slide? I'll just wait. Yeah, I'll just give you a little. I'll give you a little background of what's happened. So thank you. Early on in Confederacy, there were a lot of skirmishes, as you might know, across the U.S. Upper Canada border. And in fact, Quebec City is one of the major areas of skirmish. We call them skirmishes because we're Canadian. We don't like to say war or battles, skirmishes. And one of the major areas of skirmish was actually Amherstburg, which is just over a few miles from what you see directly across from downtown, where the Americans tried to alight upon canoes in the dark. And we roused up both Native Americans, we call them Native Canadians actually, as well as British troops, and beat them back, as they say. So that is why, in fact, when you look across the border, Windsor is south of Detroit. So we're actually a warmer place than Detroit. So if you ever get a chance to come to Windsor, please do. It's a wonderful place. As you see, it's almost like a little village. But I guarantee you the food is good, the people are warm, and the currency exchange is wonderful. Okay, I was asked to update you on some of our work we've done with the HS QoL, and I thought I would take the opportunity to change that up completely. Most conveners hate that, but I thought it would only be the right thing to do because there have been a lot of new measures developed. So I think for this audience, it's best to give you an update on what's happened in the quality of life or patient-reported outcomes field. What I wanted to do was just to make sure that you understand that I do have lots of conflicts of interest, and some of them are regarding the intellectual property, but I do take medications for these, so my conflicts are under control right now. The agenda is going to be very straightforward. Why do we talk about patient-reported outcomes, and why don't we use the word quality of life, and are they different in some way, or maybe they're part of the other? What are the current HS patient-reported outcome, otherwise known as PRO measures, and what is their current status in development? Okay, so I'm going to just condense it in those types of tight bites and try to work forward rather than just focusing on one, which was what you saw in the abstract. So quality of life, as you understand from the dimensional perspective, is the essence of the textures and the beauty and the quality. Is kind of like the tapestry of your life. It encompasses your emotions, your physicality, your sexuality, how you incorporate into your workplace and your environment. So it's multifaceted. Patient-reported outcomes don't have to be. They can be very singular. They can only be asking about pain, for example, or they can be asking about urinary function if you're wondering about prostatic interventions, for example. Or they can be multidimensional, focused on aspects relevant to quality of life. So patient-reported outcome measures in the clinical trial jargon is very specific for what comes from the patient directly without any interpretation by anybody else. Okay? That's why when we provide these surveys to patients, we give them the instructions, we tell them to do it to the best of their ability, and then we leave them alone and we don't interpret. Okay? So that's the major difference between a PRO and a QoL. And sometimes you'll hear people use them interchangeably, but when they use it in the sense of a PRO, a patient-reported outcome, they're talking now within the context of a clinical research paradigm. Oh, by the way, the WHO and quality of life most often is used in terms of economics, gender-based inequality issues, as well as poverty-related issues. So it's used in a very different way sometimes than we think about using it in the medical literature. Okay, so patient-reported outcomes, why do we need to measure it? Well, within the context of HS, it allows us to focus on what's important to patients. Because a lot of times as observers, as clinicians, we don't really understand what the critical aspects are, because what we see is not necessarily what they feel or what is impacted upon their life and the quality of their life. So what signs, symptoms, what impacts are important to HS patients. One of the other reasons to do this is because when we develop interventional studies, it's important to understand whether we're targeting these as primary or secondary outcome objectives. Now, this particular set of little colored figures is from the FDA Pro guidelines. And it shows you this is a very standard and typical way of looking at treatment and clinical trials for treatment. That is, treatment of disease X. And the endpoint there is a physiologic one, a pathophysiologic one, which is usually a clinical response outcome. So that means number of lesions, size of lesions, extent of lesions, and so on and so forth. However, the other model that they allow is one that is treatment related to symptoms of the disease. And in that situation, the primary endpoint is actually symptoms or signs or impact. Okay, so you can develop your paradigm for your clinical trial based on endpoints that you think are relevant to that intervention. Okay. Now I do that. Arrow towards me. Oh, okay, thank you. So from disease to illness, this is a very simple conceptual way of thinking about how disease impacts man and how that person, that human, now has to deal with the illness of the disease. So from the clinical pathologic onto the signs and symptoms, and then the impacts on their life. And what can treatment do? Well, it can probably at least affect clinical pathologic early on. Okay, and those are clinical reported outcomes. And then what we need to find out from patients are signs, symptoms, and impacts, which is what they report to us as patient-reported outcomes. And when we develop PROs, the process is really always this way now. Okay, in the past, it used to be a group of colleagues sitting around coffee and saying, what do you think we need to measure that will be important in this target condition? Okay, so for example, some of the very old quality of life scales were developed that way. So now it looks at it in a very different paradigm. We start with patients. The question is, the concept elicitation phase is always derived from what patients tell us in a very open-ended way. Then we talk about how best to measure these items. That is, how do we administer it? These are all the kind of instructional aspects. How do we phrase it? Is it phrased in a way that people understand it? What is the duration that we want them to refer to? Is it 1 day? Is it 1 month? Is it 1 week? What is recall bias? And all of those are relevant to how best to measure. And then we go back to patients. Once we have those established, we ask the patients again, do they understand these words? Do they understand the concepts we're trying to elicit? Do they give us, is there some ambiguity or not? And then we move on to psychometric evaluation. And what that means is we try to understand whether what we're developing is measuring what we mean it to measure. So that requires us to have another measure to compare it to, and that's called construct validation or convergent validity. And then the last is, how does it perform as an instrument? So what we then do is to evaluate responsivity and reliability. Okay, so those are all the sequence of developing these tools. Aren't you excited? I know you're all on tenterhooks. Usually when I say quality of life, people's eyes glaze over. They look for their drinks, or they look for their PDA. So here's the conceptual model for HS. We talked about clinical pathologic, signs and symptoms, impacts. Okay, and you can see how one flows to the other, and you can expand that to a variety of different textural impacts that are all relevant to people's lives. So how do you condense it and make it workable? Well, the first thing we want to understand is what is the time frame for improvement, and this allows you to contextualize the question timing, the framing of the question itself. Clinical pathologic might be relatively short if you can subside information rapidly. then it leads to aspects of reduction in signs and symptoms, but impacts might be very slow in changing. And the reason is because some of those aspects may have long duration lag times. For example, if patients have been underemployed, simply because you reduce their inflammation doesn't mean they're going to be changing their employment or modulating the way they deal with things that they've had to deal with scarring, for example, in HS. So what I wanted to show you now is where are we with the HS Pro development with the different scales. Here are the current Pro scales that are available. So this one was just released by the AbbVie and the group with input from Alexa Kimball. And that just came out, which is why I thought it would be important for me to change the scope of this presentation. The second was HS QoL that we just published also very recently. So I think those two are the two that have made it to publication. This one, High SQoL, which is in this pink coloration, is there because it's still in development, but we know it's moving along very rapidly, and it's being developed by the historic work group that includes Jocelyn as well as Amit and myself. Okay, so this is the AbbVie sponsored scale, and this particular one comprises these two particular scores, and I'll show you what they look like. The HSSA score, which is symptom and sign assessment, as well as a separate one, which is the impact assessment. So it's very clearly distinguished, just remember those concepts of signs and symptoms as domain 1, distinct from impact, which is domain 2. And they've separated into two different scales. Why did they do that? Because number one, I think it belonged in two different categories. But now you can pick and choose. If you're targeting a disease sign and symptom, you're trying to modify that, that might be then your primary outcome measure. Or if you're trying to address impacts, that's a different measure. Okay, so I think it's a very well thought out scale that way. So where are they as far as development goes? So how far along are they? They're all the way out to psychometric evaluation. They evaluated against another pain scale, a work productivity scale. And they're at the level now of finishing clinometric evaluation because they don't have a measure yet of how responsive it is to intervention. Okay, so I think what they'll be looking at is moving on to evaluate this probably in a clinical trial process for determination of clinometrics. Okay, and if for permission to use it, this is the contact person at AbbVie. So if you need to photograph it, I'll get out of the way. Or if you, in fact, if you need my slides, just let me know. I can PDF this to you. Okay, I'm sorry. Somebody was photographing. You got it? Okay. All right, and this is the one we've just published as well. It's called HS QoL. And this particular one, you'll see a lot of these types of correlation analyses. Thank goodness you have grad students, right? So the correlation analyses are based on your measure and also the other convergence scales that you're trying to evaluate. And what you're trying to do is try to understand whether each of these have good intra-class correlation. And what you see here is these are called Cronbach alphas that tell you that there's confirmation that these items all belong together. And then there is also evaluations against different scales. And you can see basically all these numbers indicate to you whether they're highly correlated or less highly correlated. Anything beyond 0.6, 0.7 is considered reasonable correlation. 1 is perfect correlation, which usually isn't available unless you're just measuring it against itself, which is why you get 1s, okay? But that's where symptoms are evaluated against symptoms. So that just gives you a way to understand what these numbers are all about. And where is HS QoL in development and validation? Well, we brought it all the way out to psychometric evaluation. We were waiting to go into clinometrics. And this is a 7-domain, 44 items scale. And I can certainly make sure you have access to it if you want to use it. And what happened in May of this year at the IDIOM meeting is that the historic group and myself decided we needed to join together. And the reason is we thought we could move the efforts of HS QoL and PROs together more quickly in a much more validated way and to do it more, more widespread global fashion. So we stopped development of HS QoL and moved it into the historic group. This is where the HiSQoL development is at this point. HiSQoL, we joined in at this level, so we've moved them along all the way through here with Jocelyn and Linnea's help in Denmark. And we're at the level now of going on to confirming and then going on to psychometric evaluation, hopefully in some of the clinical trials. Okay. So this is what HiSQoL looks like. It has 10 domains and 43 items. There's also a specific question here on overall quality of life. And I wanted to show you some of the differences between the AbbVie scale as well compared to the HiSQoL. So regarding signs and symptoms, the commonalities are pain, drainage, malodor. I'll try to get out of the way without falling off. Malodor and itch. So these are the disparate aspects, which is the redness part in HSSA, tenderness, but HiSQoL has descriptions of red lumps or knots and skin tightness or pulling. What's interesting about HiSQoL is it talks about fatigue and flu-like symptoms that isn't in HSSA. So I think some of those we'll need to try to reconcile, because those are actually really important aspects that have been either missed or that we've included. So there are issues here that I think need a little bit more clarification. These are regarding the impacts, so lots of common impacts, but look at the ones that are disparate. Okay, I just did that. Here we go. The ones that are disparate are being bothered in HSSA, but what we asked about was overall quality of life. So those two might be similar, actually. Okay, it's just coming at that psychological construct a different way. We asked about ability to concentrate at work or at school or at play, that because you might be distracted by pain or drainage. They didn't ask about that at all, which I think is kind of unusual. Satisfaction with therapy was asked in HSSA, which is probably a separate PRO. If you're asking about satisfaction of therapy and you're doing interventional therapy, I think it's probably best to be put outside in a different set of questions. And then bothered by scarring is very specific to this questionnaire, and it's not in HiSQoL. Okay, so this is what HiSQoL looks like. And we're here, so if you're interested in using it, feel free to address it and bring it up with any of us. So I've tried to summarize for you a couple of very simple, but maybe not otherwise obvious constructs or concepts. One is the difference between a patient-reported outcome and a quality of life measure. The second is the development of quality of life measures and PROs are very distinct now and very clearly demarcated based on how to establish them in a validated and credible manner. So these steps are always done over and over again if you want to get to a well-developed and defensible PRO. The third part is there are a number of HS PRO measures, and I've shown you where they are in different stages of development. I've also tried to be extremely practical so you'll understand how many items they are, who to ask for permission if you want to proceed or use them in your clinical research, or if you want to use them in clinical trial programs. And there is an HS survey that is now circulating and is underway that incorporates the HiSQoL. So thank you very much.